Hi, good afternoon, everyone. Welcome to the May 28th session of the Virtual Learning Collaborative, entitled Utilizing 340B for Innovative Testing, Linkage, and Treatment Programs, um, made possible in partnership with the CDC Division of Viral Hepatitis. So hi, my name is Zakia Grubbs. I'm Senior Manager here on the Hepatitis team, and the format for today's session is as follows. We will begin with a presentation from Grace Lee Parr with NASTAD, Policy and Legislative Affairs Team, Arlis Jenkins and Ricardo Fernandez with the Arizona Department of Health Services, and Gavin Ferguson with the VEN Centers, followed by a moderated discussion with Heath Johnson, who is a HepTAC Advisory Committee member. So feel free to use the chat to introduce yourselves and your jurisdiction, and if you all have any questions. So we will get started, and I will turn it over to Grace Lee.
Thank you. Thank you, Zakia. Let me go ahead and share my screen. Okay. Can everybody see that? Okay. All right. Thank you. All righty. So once again, everybody, my name is Grace Lee. I'm a legal research manager here at NASTAD, and I'm going to be discussing pharmacist authority to provide hepatitis prevention and treatment services. So first off, I just wanted to address why pharmacies for this work. And truly, it just comes down to the fact that they are much more accessible points of care than traditional healthcare providers. You know, I know for myself, I live in rural Virginia. When I go to the doctor, that is about an hour drive. And that is time and resources that are a privilege that a lot of people simply do not have. On the other hand, if I want to go to my local pharmacy, that is less than a 5-minute drive. And that's kind of an insane gap in care that is truly not uncommon for individuals that live in rural areas. So overall, first up, pharmacies are geographically much more accessible. 90% of Americans actually live within 5 miles of a pharmacy. Furthermore, they offer extended hours, some up to 24 hours a day. You can receive care without an appointment for certain services. You can simply walk in. And pharmacies can also just provide referrals and that linkage to mainstream healthcare. Overall, given their accessible hours and settings, trust within communities, and ability to provide healthcare services, pharmacists are well positioned to potentially play a greater role in viral hepatitis prevention, screening, and treatment. As a result, policies authorizing pharmacists to provide and bill for these services may create the potential to expand cost-effective and life-saving preventive services and treatments vital to communities most impacted by viral hepatitis. So because of this significant potential for pharmacies to provide accessible care, NASTAD underwent a research project that looked into states' policies surrounding pharmacists' scope of practice laws. Our goal here was to really emphasize the vital role that community pharmacies play in preventing hepatitis transmissions and providing hepatitis treatment services. So in doing this research, we looked into not only all 50 states, but also DC and Puerto Rico. And in doing this research, we really focused in on 5 areas of pharmacist scope of practice laws. We looked at their ability to administer HIV and HPV vaccinations, the ability to conduct rapid HCV tests, whether they were able to be reimbursed for the provision of these clinical services. We looked into prior authorization requirements for DAAs. And then finally, we looked into their ability to participate in what is known as a collaborative practice agreement and what exactly is the scope that pharmacists could provide under those agreements. And I'm going to briefly walk through our findings for this. So first off, pharmacists in the United States have varying ability to prescribe and administer hepatitis A and B vaccinations, depending on state laws and regulations. In every state, pharmacists can administer these vaccinations, but whether a prescription from a primary care provider is required varies greatly. In states where pharmacists are authorized to prescribe and administer vaccinations, this is often done through statewide protocols or statewide standing orders, which enable pharmacists to both prescribe and administer these vaccines under certain conditions. Other states have also sought like more permanent expansion, which is statutorily expanding their scope of practice to include the prescribing and administering of these vaccinations. So in doing our research, we identified that out of all 52 jurisdictions we looked into, only 21 jurisdictions actually permit pharmacists to do this work without a prescription. The majority of states then require pharmacists to either have a prescription directly from a primary care provider or to be working under a protocol or collaborative practice agreement. So the second topic that we looked into was pharmacists' ability to conduct rapid hepatitis C tests. So pharmacists in some jurisdictions are able to independently test for hepatitis C through what are known as CLIA wave tests. CLIA wave tests are simple tests with a low risk for an incorrect result. These tests include those that the FDA has cleared for home use and tests approved for waiver under this CLIA statute, which is why they are known as CLIA waived. The CLIA wave tests include both the rapid HCV antibody test as well as the newly FDA approved point of care HCV RNA test. So the ability to conduct both of these tests would enable pharmacists to actually complete the two-step HCV testing sequence in a single visit. This practice would allow individuals who test positive for the HCV RNA to be immediately leaked to treatment. So this would be an example of pharmacies providing that immediate warm handoff to mainstream healthcare services. However, in research, we did identify that only 12 jurisdictions out of the 52 we looked into allow pharmacists to independently conduct these tests. In all other jurisdictions, same with prescribing vaccinations, pharmacists must be operating either under a protocol or a collaborative practice agreement with a primary care provider to perform this kind of testing. So when discussing pharmacists' ability to independently prescribe and administer HIV and HBV vaccinations, as well as their ability to independently conduct rapid HCV tests, it's pivotal that we also address the issue of reimbursement. The reason for that is because pharmacists are not federally defined as providers. Now, the reason that this is an issue is because unless a state statute says otherwise, this means that pharmacists are not guaranteed reimbursement for the provision of clinical services. So what this means is that even if a state authorizes pharmacists to perform these services without that guarantee of payment, pharmacists have no logistical incentive to do so. So as a result, statutorily mandated reimbursement is contingent on these states passing legislation explicitly requiring insurers, including state Medicaid programs, to reimburse pharmacists for their clinical services to ensure they're compensated for their work. So in doing this research, we identified that out of the 52 jurisdictions we looked into, only 27 require state Medicaid to reimburse pharmacists for the provision of these clinical services. So again, I really just want to hammer home that without the assurance that they will be reimbursed, pharmacists have no financial incentive to implement viral hepatitis prevention, screening, and treatment services into their scope of work. We also looked into prior authorization requirements for direct-acting antiviral medications under Medicaid. These prior authorization requirements create significant challenges for patients with HCV and for healthcare providers. This delays treatment and complicates access to life-saving medication. In order to increase HCV treatment uptake and to decrease both the public health and financial strain of the epidemic, states need to either pursue or expand current legislative efforts to reduce or fully eliminate the barrier of prior authorization requirements for DAAs. So in this research that we conducted, out of the 52 jurisdictions, 25 require prior authorization for HCV DAA medication, specifically under Medicaid, which again creates a significant barrier to timely and efficient treatment. The final category that we looked into when conducting this research was that of collaborative practice agreements. For some of those services that we researched, I mentioned that pharmacists may not be able to do so independently, but they might be able to do so through a collaborative practice agreement. So I just first wanted to expand on what exactly that is. So a collaborative practice agreement establishes a contractual relationship between a primary care provider and a pharmacist, where the pharmacist scope of practice is expanded through that collaboration with the primary care provider. Essentially, what happens is a physician will delegate certain patient care services to that pharmacist. So for viral hepatitis services, CPAs offer a potential way to expand a pharmacist scope of practice to authorize pharmacists to order and interpret laboratory test results, prescribe and administer vaccinations, conducting CLIA waive tests for viral hepatitis if they do not already have that authority to do so, all without an individual prescription. So overall, CPAs offer an option in situations where pharmacists would be otherwise restricted from independently providing comprehensive viral hepatitis care. So we looked into a few different things specifically in terms of collaborative practice agreement. The first thing we identified is that the majority of jurisdictions, 34, permit pharmacists to enter into what are known as non-patient specific CPAs, meaning that they don't have to specify the patients that they are providing care to. They just have to identify the general population. So for terms of providing vaccinations, that would look very generally just as individuals at risk of contracting HIV or HBV. That would be the generalized populations that would be eligible for care under this CPA. Another thing we looked into in CPAs is that all but 3 jurisdictions allow pharmacists to order laboratory tests under CPA. However, only 32 actually enable pharmacists to interpret laboratory test results. So that was a pretty significant drop. And then finally, we looked into, that was the final thing. We looked into whether jurisdictions enable pharmacists to interpret those laboratory test results. So overall, if more jurisdictions were to move to grant broader authority to pharmacists, CPAs can be leveraged by pharmacists in their communities to increase access to viral hepatitis services. So finally, I'm going to close with a little plug for an upcoming resource that NASTAD has. We have an issue brief coming out called Pharmacist Authority to Provide Viral Hepatitis Prevention, Testing, and Treatment Services. So this is an issue brief as well as simply a downloadable resource. If you look to the right here, this is what the tables that go over all of the research that I just mentioned looks like. It identifies the state, the legal authority, and very briefly answers questions regarding that authority. For example, whether they can administer those vaccinations without a prescription, and if there are age requirements. So in addition to those tables, the issue brief also simply expands upon issues impacting pharmacists' ability to provide these services, and then it recommends best practices for addressing those barriers. So with that, I am going to pause for questions if anybody has any. think there's some in the chat. Let me see. It will be online. We are hoping to publish in the next 3 weeks. It has approval from CDC. We are simply just kind of in that last approval process for dissemination plans. But yes, we can share it individually as well. Thank you as well. And if there are no other questions, I think I will pass it on.
Thank you, Grace Lee. I think we have Arlis and Ricardo next.
All right, we'll get our slides up. So thank you, April. Okay. Good afternoon, everyone. It's a pleasure to be here and talk about 340B partnerships that we've established in Arizona and how we're striving to enhance and expand Hep C services to bring us closer to ending the epidemics. My name is Arlis Jenkins. I use she, her pronouns. I work on the Hep C team at the Arizona Department of Health Services, and I'm joined by my colleague as well. I'll let him introduce himself.
Hello, everyone. I'm Ricardo Fernandez. I work with Arlis at the Arizona Department of Health Services in the Office of HIV and Hepatitis C.
Perfect. You can go to the next slide. And one more slide. All right. So as mentioned, we work at ADHS within the Office of HIV and Hepatitis C Services, where programs are responsible for both surveillance and prevention activities. This includes collecting and analyzing data, conducting case investigations, providing patient navigation services for Hep C, along with the co-facilitation of community advisory groups such as the HIV Statewide Advisory Group and the Hep Free AZ Coalition, among many other activities. And these activities take place within the state that has over 7.6 million residents, 15 counties, 22 tribal jurisdictions, and a border with Mexico. So there's lots of unique challenges statewide. You can go to the next slide. All right. The Hep C team is now a team of 5 individuals. We wear many hats, as I'm sure many of you on the call can relate. We have CDC viral hepatitis funding, but also CDC SetNet programming, perinatal Hep C programming, and Gilead Relink programming as well, re-engagement. So our team, starting on the top left, we have Priscilla, our data entry specialist, Vera, our investigator navigator, and then myself. In the bottom left, we have April, our senior epidemiologist, and then Saul, our other investigator navigator. And then not pictured, we do have an intern for a little bit longer before she graduates who works on perinatal Hep C activities. Next slide. Okay, I want to take a moment to provide some context to the landscape in which these 340B programs are operating. While we've seen a lot of positive changes, some challenges still remain. On the statofhepc.org website, we are listed as an A, but we do have an asterisk, as our state Medicaid does require prior authorization for individuals who were previously dispensed direct-acting antivirals, which complicates retreatment. There are also restrictions for lost or stolen medications as well. And I want to note that while Medicaid is one of the more common payers, it is not the only insurer, so we do see varying challenges with commercial insurances and inconsistencies in funding availability with patient assistance programs, as I'm sure many of you can relate. In terms of prevention, we have syringe service programs that were legalized in 2021, but the volume and reach are quite limited, with less than a dozen entities providing these services throughout the state. So throughout the last 5 years in particular, a few key strategies have emerged for our Hep C team, including direct service provision, such as the navigation work we do, funding subcontractors directly, and the in-kind support we provide to extend authority and to orgs to become covered entities and form their own 340B programs. So the first 2 strategies focus heavily on patient navigation with our ADHS team and testing and linkage to care at Maricopa County, one of our most populous counties. But the third one has led to many additional partnerships and the implementation of evidence-based practices that we may not have otherwise seen, if not for 340B programming. It also extends the reach to provide services to disproportionately impacted populations that these orgs have already formed solid relationships with. You can go to the next slide. Okay, so we'll dig a little deeper into the 340B strategy. Next slide. All right. The goal of the program is to expand and enhance hepatitis C services for us by extending eligibility for organizations to develop these programs. In general, we followed a simple yet effective approach to forming these partnerships. We typically set up one-on-one meetings with healthcare providers. And the sole focus of these meetings is not always just 340B. Sometimes it's we're introducing ourselves, and discussions are also sometimes more syndemic based as well, involving HIV and STI colleagues on the calls. And during these interactions, we would assess if 340B programming is already in place, what the entity's payer mix looks like, and what their goals are for the future. Since 340B programming does involve reinvesting those savings back into programming, that's something that we always check in on, as well as the commitment to starting up the program and the maintenance they would need along the way for quality assurance. If it is decided that we will proceed, we then look to establish a memorandum of understanding or an intergovernmental agreement using boilerplate language and incorporating specifics for that entity into the scope of work. And there's quite a few reporting requirements as well that we typically include. Lastly, we do our onboarding, and that is where we kind of get that support in place for the data reporting. The HepC team uses a REDCap database specifically for groups that have 340B programs to maintain the positive and negative reports. And then we set up reoccurring meetings to provide technical assistance and training and share back what we're hearing other groups are doing and have key discussions as well. So there's usually more meetings in the beginning, and then it might taper off a little bit as the program stands up. Next slide. All right. So at a glance, you could see some of the groups that we have these partnerships with. The ones listed here are more specifically focused on Hep C. However, we do have other groups as an office and as an agency that will maybe start with HIV or STI focus and then later expand to do more Hep C work. So we try to be mindful of that as well. Right in the middle there is Arizona Liver Health or VEN Centers, who you'll hear from just a little bit. We officially initiated our agreement with them in fall of 2021, and we've seen tremendous growth since then. To call out some of the other partners we work with, we do have an agreement with our state correctional system. They have a different 340B program model, but they've had that in place since 2019. Also, academic centers such as University of Arizona has a specialty clinic with 340B program. And then we have several community-based organizations, some of which hire peers, provide outreach, including mobile unit testing, offer extended hours for testing, and linkage to care and telemedicine as well, in part through some of the 340B programming. Next slide. All right. And last slide here, just to provide some additional detail on what makes the partnership with VEN Centers so unique. Starting with the well-established presence they had long before this agreement was established, decades of experience with their providers. I know when I first started, I heard everybody mention the name of one of the providers, Dr. Richard Manch. He was quite well known, so I knew I had to meet that person right away. He runs a Project Echo with some of his colleagues focused on Hep C treatment for rural primary care providers. And then through some of these partnerships, they helped co-found the Hep Free AZ Coalition. So definitely a lot of history and expertise already in place. And then the evidence-based practices, they hire peers and individuals who are local to the regions they're serving. They have outreach teams, mobile units. You're going to hear a lot more about this, including their research on the Cepheid point of care test and a TIA research trial. And then lastly, they had such a strong foundation with Arizona Liver Health being an established specialty clinic with an ideal payer mix. And again, having that subject matter expertise. And then something that really can't be understated would be the partnerships they've already had with existing orgs and the new ones that they formed as well. You can go to the next slide. All right, and with that, I'll conclude our portion of the presentation. I know I speak for more than myself when I say we could not be happier with the partnerships in place and the general effectiveness of 340B programming. And we're open to answering any questions now or at the end of the presentation. Thank you.
Yeah, thank you so much, Arlis. I think we can move to Gavin's presentation.
Good afternoon, everybody. Let me get this presentation pulled up here. Is everybody able to see that and hear me okay?
Oh, I don't see the presentation yet.
That's because I actually need to share my screen. Getting a little
No
bit.
worries.
How about now?
No. Unless someone else can see it, I can't.
No, I can't see it either.
Oh, we got a
Oh.
little bit of a delay.
There you
we
go.
are.
Yeah, there we go.
All right. Figured it out. So my name is Gavin Ferguson. I'm a PA with VEN Centers, and as you just heard Arlis talk on, part of Arizona Liver Health. And I'll be speaking to you briefly today about our rapid startup field-based point-of-care testing for hepatitis C elimination that was largely enabled by a state-funded 340B initiative. With this presentations, there are no relative disclosures. So I'll get into a little bit of the history that Arlis did touch on. Arizona Liver Health was the largest treater of hepatitis C in Arizona. And that is entirely due to the providers and company leaders that we have with Dr. Manch, as he was mentioned, and Moore, who's been working with Dr. Manch for a good 30 years or so, and then Dr. Coley, who has her expertise with infectious disease and the CDC, and Hep C is kind of a passion project for her. That's what she did a lot of her research in, and that's why she is so willing to create VEN centers and allow us to do the work that we do. But this work wouldn't be possible without the ALH 340B status that the Arizona Department of Health Services granted through that MOU. And those funds are primarily to be used for the elimination of Hep C and to provide access to STI care, as well as a small amount of PrEP and PEP services. Largely the PrEP and PEP services that we do see patients for, there's maybe been 5 out of 500 that are interested in those services, and that's namely because those services are available elsewhere, but we fill in where we can. In Arizona, we've got an estimated 90,000 patients with a Hep C diagnosis and 10,000 new cases annually. Up to 50% of the people don't even know that they have hepatitis C, and right now, unfortunately, our infection rate is higher than our cure rate, so we are fighting an uphill battle when it comes to this. And one of the key points of this presentation is the aspect of collaboration that I'll get to shortly, because that's the only way we're going to make a meaningful change in the rates of infection and the cure rates as well. So with ALH being the largest treater of hepatitis C in Arizona, they were only seeing about 150 patients per year, roughly 12 to 13. So we had to do something different, think outside the box, or copy a wheel that was already in process in other states. And I think we've done a fairly decent job of that. But to get some insight from the people that we're serving, we went to patients, both prior and current. We went to Pennsylvania to Central Outreach to see how they're doing their program. And as Arlis mentioned again, Hep C Free AZ, the ECHO program, and then harm reduction groups in Arizona. And we asked those questions about the pitfalls and perils of access to care, what the frustrations were, and how we could address those concerns. And from that, we created VEN Centers. And I'm not going to go through the entire vision and mission statement, but I do want to focus on this value right here, the collaboration with partner groups in the community. Collaboration, and that's why we're all here for this setting right now, is collaboration so we can build off of each other's work and provide better care to our patients in our communities. And you can see that collaboration is absolutely the name of the game. There are different missions here. There are food centers. There are mental health agencies like Southwest. There are harm reduction groups, safe use groups, community assistant groups that we all partner with. And when it comes down to it, we don't care who does the treating. We want to make sure that the individual gets their Hep C treatment. So if it's VEN Centers that gets to see the patient, great, that's wonderful. If we can connect them to another provider or another group in their community and they still get that treatment, that's great too. So we don't have a tie to the outcome necessarily. We just want to make sure that people are being seen and being treated and they have that access to care. And you can see just from this little infographic that Arizona Liver Health had 5 different clinical sites throughout Arizona: Flagstaff, Glendale, I believe Mesa and Chandler, or excuse me, Peoria, not Glendale, and then Tucson. And all of these little dots here are partner groups that we work with where we've treated patients. And this graphic has even more dots now, but we just haven't updated it. We've got folks in Wickenburg, Wilcox, Meadview, which is way up here above the Grand Canyon and difficult to access, but we'll still get individuals out there as part of our outreach teams. And you can see that the numbers reflect the work that has been done. So Arizona Liver Health treated 150 patients a year. Through VEN Centers, we average right around between 120 to 140 patients per month. But you can see in some of the previous months in 2024, we were seeing close to 160 patients for Hep C specifically. This doesn't necessarily mean that they have an active viremia. This means that they've screened positive for an antibody. They're seeing us for the confirmatory phlebotomy and seeing a provider to get the ball rolling on treatment. So you can see that we're making an impact. And to provide more of a focused view, we like to bring up this individual. His name is Johnny, not his real name, obviously, but he gave us permission to not use all of his PHI, but to tell his story because he feels that it was important and the struggles that he dealt with in trying to access hepatitis C care. So he'd known for over a decade that he had hepatitis C, and he was diagnosed in prison, and he was told initially in DOC that he wasn't sick enough. And his story is not unique. Dozens, if not hundreds of my patients have brought that up. I was diagnosed when I went into prison in 2012. I was told I was too sick. And then when they were trying to get treatment, they were told that they don't have enough time left on their incarceration to be able to get treatment. Now, fortunately, there's a phenomenal provider with NAFCare, Amy Rust, who is providing Hep C treatment within DOC at the facilities that she covers. So that the commonality of that story is changing because she's getting people access to care. But when Johnny got out, he tried to find Hep C treatment locally and then realized that it was too expensive. His fibrosis score was not high enough. And again, he was told that his levels were too low. So there was this misinformation and misconceptions out there about who could receive treatment. And we have to look at this through the experience of what he is going through. This is an individual that just got out of DOC. So work is going to be hard to find with a felony conviction. Housing is going to be difficult. Parole or probation requirements are going to be forefront so he doesn't have anything revoked and have to go back to jail or prison. So consider that spot in life where people are, and when they're trying to get Hep C treatment, they don't care about an insidious disease process that will take years and decades to affect a change in their health. They're worried about the then and now and getting their basic needs met. And currently, this is what the access to care and access to treatment looks like for most people. We've got up to 4 different visits that people have to go through in order to get prescribed a medication. And that medication only gets to the patient if it's actually approved by the insurance. Sometimes it's caught in the purgatory of prior authorizations, and it's due to one lab value not being present. And providers just get frustrated and they don't follow through with it, or they don't have the ability with the staffing that they have to follow through with it. So VEN Centers' whole goal was to minimize the number of visits that it took to get medications in hand. And we've got it down to 1 visit. So you're going to see this slide quite a bit as I highlight different aspects of it. But you can see here circled in what I assume is red. I'm red-green colorblind, and I did not make this slide, so I assume that's red, could be green. But I'll highlight these different points with the screening and the intake process, the provider visit, and the confirmation phlebotomy. But also I want to focus on the case management aspect, which is what has really made VEN Centers successful. Additionally, these other 4 aspects of the care cascade within our EHR, when a prescription is sent in for a Hep C medication, it goes to our medication assistance team. And that's an internal framework that we have set up that starts their process to monitor for lab results, to start the PA process if it's needed, especially with private insurance. But that allows the care to start concurrently instead of having all of the medical side done and then the pharmacy and then the prior auth side done. It's all completed concurrently. So the screening aspect of it, and screening to us is our outreach teams. And as Grace Lee mentioned, the CLIA waiver tests, our outreach teams go out to the community with backpacks and in our vans filled with the tests and the phlebotomy supplies, as well as snacks and water, just as an enticement for folks to test. They don't have to test to receive those. We hand them out freely. And that helps to break the ice. As public health departments in general, it's not sufficient to just have a brick and mortar clinic and invite patients to come to you. It's not sufficient to have a mobile unit that you post in a stationary location. And even if it rotates around your community, it's not sufficient to invite people to you. You've got to have boots on the ground with your outreach team in the community, going to the places that nobody else wants to visit, because that's the folks that haven't had access to care yet. So we're going to treatment facilities, mat service facilities. We're providing education and testing and treatment at the same time. We are going to encampments throughout the city where we know that there is a lot of high-risk individuals. We will drive through the city and stop at different intersections and just walk around the intersections talking to people that appear to be high risk, or we can visually see that they are in the midst of their substance use, and we're engaging with them, we're getting them screened, we're providing that education and testing for them. So again, as health departments, if you're the director, if you're the manager, you've got to be thinking of ways to have these outreach teams funded, which is where the 340B side of it comes in, because that can be used for, Hep C elimination. But getting those outreach teams in the community where people are at and getting them taken care of. And if somebody screens positive, they start the intake process. Or if they come up to us and say, hey, I already know that I'm positive, I want treatment, that starts the intake process as well. And it's a straightforward intake process. We get a lot of information on where to find the patient. So social media, phone contacts, friends, family members that we can reach out to. If we can't find the patient, we ask where they like to hang out. Literally, what underpass do you stay at? What section of the tunnels are you at? 100 Acres is a large encampment in Tucson. We ask people where they're located. So we do everything that we can to find patients so there's less loss to follow up. And our outreach team could be private investigators. They find people that a lot of the times just don't have a connection to the normal flows of society, but we go out to those areas and we find them. The remainder of the intake side of it is just contracts and consent forms to be able to treat, and then the pharmacy release form. So we can deliver medication directly to the patient. We can have the medication delivered to us and then bring it to the individual if they're unhoused, or we can have the medication sent to a facility and have them administer the medication. And you can see some of our outreach in action here in various settings. Top left is Church of Safe Injection in Tucson. Bottom left is Andre House. Top right is an encampment in Phoenix. And bottom right is a transition group for recently released individuals from DOC, where we provided education and testing. And you can see the volume of tests that we can run at one time. This here, where you see Dylan and Lupe, and Dylan's our director, Lupe is one of our Northern Arizona outreach team members. They're using a Cepheid gene expert machine. We don't have time to go into that right now, but my contact information is in the chat and at the end of this presentation. Cepheid has the ability to make some changes in how quickly we get meds to people. It offers a hepatitis C RNA qualitative result in about 45 to 60 minutes. So as part of the all-in-one model that we use, we have immediate access to a telehealth provider visit. Typically that's me, but it can also be one of our other providers within the company. Or I see patients directly face-to-face if I'm in the field with the teams doing testing and phlebotomy alongside them. As providers, we have a very small role in the entirety of access to care and the treatment side of it. For providers, we have to be more comfortable prescribing medications in less than ideal settings. One of the issues that we hear quite regularly is unrecognized hepatitis B and the fear of reactivation. Well, the reactivation rates are somewhere between 0% and 0.1%, so it's pretty low. So again, providers have to be very comfortable with less than ideal settings, have the conversation with patients, but don't withhold care because of missing labs that, when it gets down to it, aren't critical for them to receive Hep C treatment, or lifestyle choices, whether it's active use, unstable housing, anything like that. Those should not be barriers to prescribing medication. So education for providers is important. And when you're looking at the providers as part of your health department groups, they have to be willing to work with marginalized, underserved groups and be out there along with the outreach teams to perform these tasks. One of the last parts of the actual one visit model is the confirmation phlebotomy. So that's done in the field, and all of our outreach teams are phlebotomists, and they're very good at what they do. I recently got recertified. I haven't done phlebotomy since I was an EMT almost 20 years ago, but our phlebotomists and outreach team members have highly honed skills, and with the demographic that we work with and when we see, they have a extensive IV substance use history to where venipuncture can be difficult. But if you have to send a person out to another facility for an ultrasound guided lab draw, you may lose the ability to connect that patient to care. So that needs to be a consideration when hiring those outreach individuals. Make sure that the phlebotomy is emphasized as well. Now, with that concurrent approach that we take, this cascade happens as soon as the labs and the prescription are sent in our EHR. The pharmacy and care management team are alerted on the patient and can track lab results. They can start looking at previous dispensation of medications, things of that nature. But the most important part of all of this is the case management. Our case managers have a minimum of 8 or so contact points with the patient. And that helps to create this consistency, this familiarity and trust for the patient to where they know that, yes, I've come from this marginalized group that hasn't been able to receive good care throughout most of my life, and there's still this stigmatization about it. But this constancy and this comprehensive contact with them really builds that trust. And that's why we are successful. Again, as a provider, writing the script for Mavyret or Epclusa or Vosevi is easy. Looking at labs is easy. The real bulk of the work happens with our outreach teams and our case management. Right? With what all we're doing, we still have some areas that we need to focus on. So by creating this one visit model, we've improved that access to care, but that can improve. We just need to have more people out there doing it. We need to decrease the treatment process steps, as I've discussed, and the barriers to care. Arizona has done a wonderful job of removing, at least with access, has removed many of the barriers. So we don't have to have biopsies. We don't have a sobriety requirement for patients to receive care. And that's been key in providing medication to more people. Through our education efforts, we decrease that stigmatization and misconceptions. Going back to DOC, a lot of the old hat guys will talk about interferon and ribavirin and discourage some of the younger individuals from getting treatment. And so we work against that as well to tell them how easy it is to take the DAAs and how few side effects they have. So and with all the case management, we can improve patient tracking methods so your health departments can receive information from groups like VEN Centers about cure rates and who all is getting treated. So getting back to Johnny, he completed his entire intake process within 30 minutes. Our pharmacy team had medications in 3 days, and he had the medications in hand within 7 days. So I would like to leave you with this because this is one of my favorite quotes, and we all know that we do hard work, but far and away, the best prize that life has to offer is the chance to work hard at work worth doing. And within the realm of public health, we have a very large amount of hard work we need to do. So I appreciate all that you are doing, and I appreciate your time this afternoon. Here's my contact information, and with that, I'm going to stop sharing.
All right, thank you so much, Gavin. My name is Heath Johnson. I'm with the NASTAD HepTAC Committee, and I'll be leading us through a discussion for the remainder of the time that we have here today. Just now, Gavin, someone's asking, can you talk a little bit more about 340B and outreach services? Are you saying that 340B can be used to fund outreach services, or are you saying that 340B offsets the cost of medications, which allows money to be redirected toward outreach services?
The answer on that one would be yes. So it can be used for all those aspects, as long as the work that is being done is in line with the MOU from the state of Arizona. The outreach services can be funded through the 340B cost savings that are recognized through that whole program. Arizona is a little bit unique. We're one of 5 states that is a carve out, whereas others are carved in. So the MOUs are required for that, especially with a private group such as VEN Centers. In other states, the way 340B funding is different, and I can't speak to that directly.
Fair. Any other questions on this specific topic of how 340B is leveraged towards supporting programs like this? And anyone can feel free to put a question in the chat or raise your hand or come off mute and ask your question verbally. Okay, not hearing anything in the immediate. I'd like to circle back quickly to a question that went into the chat shortly after Grace finished her presentation. Grace, referencing your resource of the scope of work for pharmacists and different kinds of providers, can you give any insights on how different people in different jurisdictions might find the scope of work for different kinds of providers?
Yeah, so for NASTAD's research for this project, we specifically utilize Westlaw to look into each state's scope of practice laws. I did create a research protocol catered specifically to pharmacy scope of practice law. It would be very easy to edit that to try to identify scope of practice laws for other type of providers. So if that would be beneficial, happy to send that out as well.
All right, thanks, Arlis. I'm sorry, thanks, Grace Lee. Any other questions for Grace Lee or related to her research before we move on to questions for the Department of Health? Okay, seeing none just now, we'll go ahead and move on to a question for Arlis and Ricardo with the Arizona Department of Health Services. I did want to inquire, you explained your workflow, moving from one-on-one meetings with providers to establishing MOUs and then onboarding and technical assistance. I was curious, how were the providers or how are providers on an ongoing basis identified and engaged in the first place?
Absolutely. That's a really good question. I would say working really closely with the HIV and STI team, some of it has been almost organic. As we have new members or we're able to offer new services, we kind of reach out to those organizations just to stay in touch. So kind of tag teaming on those sometimes gets a good introduction to groups where this can be considered if it hadn't already. But yeah, we also have a lot of success through the Hep Free AZ Coalition, and we do a lot to try to just stay in touch. What we're working on right now is a regional guidebook where we're just asking groups to fill out a simple template and update us on what they are doing, how they do it, and how others could access those services or collaborate. So I think between sort of that in-house side and then working with the coalition, it's been helpful. But we're always striving to meet new groups and consider different ways to promote this.
Excellent. Have you encountered any consistent reasons why some providers might decline participation?
That's another good question. One thing it's somewhat related is that there's a lot of groups that already have 340B programming. So I have not seen a lot of success if they already have it and maybe getting them to shift gears and focus more on Hep C since they've well established kind of what they're dedicating those savings towards. In terms of reasons others wouldn't, I think it can be intimidating at first. There's a lot to learn. And when we onboard groups, there's often a lot of questions. And thankfully, Ricardo and other colleagues are available to answer and provide that type of support, even looking ahead to how they can do the quality assurance piece and make sure that they're staying on top of it. So I would say that'd probably be one of the main hesitations.
Okay, thanks for that. I think a follow-up question to your workflow around this is, are there deliverables in the MOUs that establish that define the reinvestments of savings from 340B pricing structure as prescribed by HRSA? That is to say, the entity enjoying 340B benefit must reinvest savings in increasing like-kind services or any requirements around that.
Absolutely. If I understand you correctly, we do have a lot of language in there about reinvesting back into Hep C, if that's what that particular MOU is for, or HIV Hep C PrEP. And that's something we discuss very much as well as we're forming those agreements. So they do need to abide by that. And in our meetings, we're checking to see, what they're using the savings on, helping brainstorm and provide that TA as well. Let me know if that answered your question.
Okay, yeah, it seems as though it did. The question was from Anne, and she says, yes, that did answer her question. So thank you very much for that. Any other questions for Arlis or related to the programming at Arizona DHS? Kind of scrolling through to see if I'm missing any hands raised. Okay. Moving on then, we'll go to Gavin with the VEN Center. What are some key challenges that you have encountered as you established the mobile outreach model? I know you described some of them. Was there anything that sticks out to you as a major barrier that you had to overcome when it was first getting started, and how you might have addressed that barrier?
We've run into a lot of treatment groups that are resistant to having a third party come into their facilities to provide care, whether it's HIPAA concerns about being able to maintain confidentiality with the folks that are testing and the test results, or there has also been some pushback based on the funding availability. So to break that down a little, if an individual needs Hep C treatment, they get transported from the treatment facility to a medical clinic and transported back. That transportation cost, at least in Arizona, can be billed out for the individual doing the transportation. And so if we're coming into a facility and we're providing that all on site, those facilities can lose out on significant funding revenue streams to continue their program. So that's one that we've run into that's been brought up by several different facilities. And then just not having our name out there initially, that's not so much the case anymore just because we've been so persistent in our outreach. But we'll get a lot of like, oh, we've got somebody that does Hep C, and we'll ask them about that process, or we'll talk to them about how often their individuals are getting treated. And it can be, 6 to 8 months versus a couple weeks. And that has been something that we've had to work to overcome, and just kind of escalating it up the chain of command at those groups. Other than that, though, it's just been a pretty open book, and showing up and working with the groups that I showed there on the slides and collaborating with them. Folks are generally receptive to having additional services brought to an area.
Excellent. Other questions for Gavin or about the VEN Center outreach program?
Hi, I have a question. I'm curious how you all hire your outreach workers. And like what are some of the key things you all are looking for when you're looking for outreach staff? Like are they specifically peers? Do they have like a knowledge or lived experience of hepatitis or general clinical services? I know you said they all get phlebotomy training. I'm just curious about like how you build like such a great outreach staff that seem willing to go like literally in the middle of nowhere and provide testing and treatment. Well, linkage treatment.
So a lot of our outreach members all have lived experience, whether it's been through previous substance use, unstable housing and homelessness. They've got work in the field just because that's what they've gravitated towards with public health and that being their passion. A lot of our staff have come from hospital settings where they just, that je ne sais quoi, they just have that ability to be out there and do that kind of thing. And the way we describe it is, you're our people. And if you don't have that genuine aspect of your care and that conviction to help individuals in these settings, the patients see right through that. I'll bring up Dr. Coley when I was hired. So I've been with the company for going on a year now. Didn't have previous experience in hepatology or Hep C, but I spent the last 7 years at a community mental health clinic in psychiatry and addiction medicine, working with the seriously mental ill diagnoses and the same demographic that I work with now, and I wouldn't have it any other way. It's easy to teach how to treat hepatitis, but if you don't have the background and that willingness, which all of our staff do, then it's usually not successful. You can't be afraid to engage with folks that are on the margins of society and that have been largely forgotten.
Yes, thank you for that. That was on my list too, Zakia. I'm glad you asked. Back in the chat now, we have a question. Is access to the internet or mobile devices for telehealth options ever an issue for folks? And how do you address that?
We haven't run into that yet. Even in some of our more rural areas, we've got cell boosters on some of the mobile units, so we're able to do that. And we just use, our ubiquitous anxiety rectangles right there to connect with people. So that hasn't really been an issue yet.
Okay.
At some point, I'm sure it will be, but then again, we've got devices like Starlink. In fact, like if I'm traveling or on the road, I've got a Starlink device set up on my truck to where I can set that up and still see patients and things like that. And it works fairly well. So the access as far as connectivity hasn't been a problem, even in some of the more remote spots up on the Dene Reservation.
Well, glad to hear that connectivity has not been a problem. One last question in the chat here. Someone may have missed it, but how many individuals is ALH now treating annually? Sorry to put you on.
Yeah, I was going back into my slide deck here. So the clinic treatment side has slowly tapered off. Right now, they're averaging right around 20 a month. So you can do the math there, and I'm not going to embarrass myself by doing it. But 20 a month or so. And that has stayed pretty consistent since VEN Centers was able to ramp up. Largely, those individuals are folks that have been diagnosed with cirrhosis or decompensated cirrhosis. So we've got that ability to tie them in directly to services, whether it's with us or a GI specialist or another community medical group. We do like to see those individuals in person and get them more surveillance and monitoring just because of the severity of the disease process.
Okay. Well, we knew that our time would be tight at the end here, and we have reached the last minute. So I'm going to pass it back to Zakia to wrap us up.
Yeah, I just wanted to say thank you all so much for sharing about the great work that you're doing. And we had a really big session. We had like a whole national overview than we had from the state level and then from our clinical partners. So we talked a lot about a lot of stuff, a lot of things to think about how we can implement in our programs. So yeah, thank you all so much for joining us today. Thank you so much for all of our presenters. Thank you, Heath, for facilitating. And yeah, we'll be back here in 2 weeks or something. I don't know, but it's on the thing. So we'll see you all soon.
You.
Take care. Thank you.